Professor Klijn from Nijmegen, the Netherlands, and I'm here today with Professor Pico from Versailles in France to talk about the results of the Rescue Brain trial. Professor Pico, can you explain to me what you set out to do in this study?
So this is a study on neuroprotection in the acute phase of stroke. We try to evaluate the remote ischemic preconditioning, which consists of inflation of a cuff in a lower limb during ischemia, reduce volume brain infarct growth in a patient within the six first hours. So it's an in-hospital neuroprotective intervention on top of IV thrombolysis and a mechanical thrombectomy.
And what were your expectations from this treatment?
So the study included 200 patients and 11 French centers, and our expectation was that remote ischemic preconditioning reduced the volume about 15 cubic centimeters.
And what did you find?
Unfortunately, we found that there was no effect of remote ischemic preconditioning on this trial with about 90% of patients who have been treated by IV thrombolysis, 1/3 by mechanical thrombectomy. And the study is neutral, no effect on imaging endpoint, infarct growth, or relative brain infarction volume, NEHSS score at 24-hour, ranking scale or rate of reperfusion, complete neutral, and no harmful also effect because it was a concern. So the symptomatic intracranial hemorrhage was have the same rate in both groups, as well as mortality at 3 months. And half of patients experience pain during remote ischemic conditioning because you inflate the cuff 210 blood pressure above the systolic blood pressure. And in this half of patients who experience pain, the median in visual analogic scale was 6.
Okay. And can you explain a little bit further why this inflation on the leg would actually have an effect on the brain?
Well, there are preclinical studies that has observed that there are some endogenous cytoprotective mechanisms that can go so with a humoral pathway or a nervous pathway with increased cerebral blood flow and also have a cytoprotective effect in a water pump in mitochondria.
Okay, and is it correct? This has also been shown in myocardial infarction to have an effect?
Yes, with a first study in myocardial infarction published in Lancet 2010 have shown that it reduces myocardial size infarct, and there is currently a large ongoing trial about more than 5,000 people with a clinical endpoint. This is the CONDI-2 study.
So what should be our final conclusion here? Is this study big enough to really show the effect that you expected? Should we continue with studies like this, or should we write off this treatment as not helping the patients? What is your opinion on that?
I think we cannot go further our conclusion because it was an in-hospital intervention. So there are currently in acute ischemic stroke 5 ongoing trials in the acute phase, and some in pre-hospital setting, 1 Danish, 1 Spanish study with clinical endpoint, and 2 other in hospital. Our conclusion is that in hospital we don't see any signal to think that it will have an effect. We can also point out that some study will repeat because we only make 1 cycle or 4 cycles of inflation, deflation, ischemic conditioning, but some study have planned to make it twice a day during 7 days. So if sooner, if more conditioning, will it be positive or not? We don't know, and I think we have to expect this study also.
And what about the magnitude of the effect? I saw in your design that you had you expected a 15 cc less increase in infarct volume, and if I'm correct, the mean infarct volume that you found in your study was about 34 or 35 cc in the patients that you included. Do you think that a 50% reduction is a realistic effect of a treatment like this, or should we power future studies for a smaller effect possibly?
Well, I think we have to make post-hoc analysis on this topic, but the 15 target have been based on first neuroprotective study with Professor Sanson, Dr. Rosso, insulin infarct, that showed that to have a clinical benefit, you have to target 15 cc. And when, for example, we look how cubic centimeter you save with IV thrombolysis, it's about 28. So, I mean, I think it makes sense now, but perhaps we will have to review our target lower in post-hoc analysis.
Well, thank you very much.
Thank you.